moving, yeah, you know it's out. Oh boy.
The good news would he would just be done for the game, but
One of the fugitives, they've already made it through. James Socolides is a big man, 7 footer.
This is the most common way to injury dislocated.
Somebody is very rough, 12 this. Swing. Swing was taken up, was out of the action for that play. It's 11 of 25 from the field, coming in defensively. Got his hand in there and something, obviously, of that left arm and shoulder.
The referee should hold up this game and let them get Wayne off the court and back to the locker room with some immediate medical attention. That look of agony on his face.
Where is this?
Okay. So what's the most common way an athlete comes to you? You can fall, but in that 90-90 position, because that's where the weakest point, right? Okay. Stretching that capsule. Okay, so slap lesion. So superior labrum and it's torn anterior posterior, and you can see right there. That's where it's torn at. Where I'll show you. This is a normal right here. So you got the biceps tendon and the labrum just all connect normally right here, and then that's where you get that tear. Yeah, superior labrum, anterior posterior.
Andy, have you seen a posterior dislocation?
Mm-hmm.
Tell them about that, because that's just not as common.
Oh, okay. Let's see. We had one last spring. What he did, he fell. He's a wide receiver, and he was going up for a catch, and then he fell on it like that, and then that's how it came out. It was just like this. And he was the one that had an anterior dislocation in the fall, came back, then posterior dislocated his other shoulder. So his rehab was a little interesting because I tell the students, I'm like, you always got to think about your anatomy and what structures you're trying to protect during, especially weights, whether they're in the weight room or not. Like if they're in the weight room doing like overhead press, so with an anterior instability, you don't want them back here doing an overhead press, you want them in here. But then with a posterior instability, you got to like reverse that, so you will put them back here rather than up here. And then also like with bench press, you're not going to want to bring them all the way back in an anterior instability. So
The most common you're going to create is the anterior dislocation, so
yes.
the abduction where it pops it forward and damages the inferior medial ligament.
mm-hmm.
And then this posterior is just a lot more rare because it's usually a trauma where that arm's driven backwards or over.
Mm-hmm. Yeah.
Abducted and pushed backwards.
And then, I mean, you can also get an inferior dislocation too.
I've never seen it.
I've never seen it either. And I hear those are really hard to get back in. Okay. And then here's just another example of where your slap lesion can be a little bit. Yeah, that's an MRI of it too. Okay. So the history of a slap tear lesion, they'll have a lot of pain with overhead activities, the popping, the catching, clicking, and they'll complain of it being deep inside the joint. And most of the time, this is an insidious onset. And then, like we talked about last time, when you're observing them, removing their shirts, seeing if they're able to get through the full range of motion, and then also how they're participating in practice, whether they're compensating one way or another. If they're a basketball player, are they like kind of bringing their shoulder down a little bit when they shoot, or are they using more of their other hand and whatnot. Exam findings, the clunk and grind test, I'll just touch base on that a little bit. And pretty much you're just trying to grind through that labrum with the glenoid into the fossa and trying to see if you can feel any grinding so external rotation with the supination that will mimic the heel of that labrum in the fossa too. And then also O'Brien's test is where you bring them across and then you resist them right here and they'll fall if they have a slap lesion. Or a posterior dislocation for that matter, because you're stretching that posterior capsule. Okay, showed you the imaging. So you can do this non-surgical and rest them, but most of the time you're not going to have a good outcome, especially if you're looking at a freshman or something who just did this and they have 4 more years of eligibility going through. Kind of like sit down with the physician and decide, do you want to deal with this like the whole entire time throughout his career, or do you want to take care of it, get surgery, get it done, and then hopefully not have any more complications. So mainly up to the team physician on that, because we do not decide whether they get surgery or not, or get MRI. So rehab concerns, I touched a little bit about that, where just the way you're doing the movements and depending on where at in it, the labrum itself or which instability they have, depends on where you're going to position the arm doing rehab and stretching the posterior structure. Okay, so this is the lateral view of the humerus, and then, or with the humerus removed. This is just to show you like the inside of that joint to give you guys a little bit of better perspective on it. Are you all through with shoulder and functional? Are they done?
Yeah, I wanted the, yeah,
They're done. Okay.
they're masters of all of it.
Okay, and these are the different complications that can come about with a dislocation. So you got the Bankart lesion. We'll go through all these too. I can kind of just hop back and forth between this page to give you guys a better example. Okay, so. Okay, so here's the Bankart, and this is where the anterior ligaments are torn, and you can see the difference between a Bankart and a Hill-Sachs. So the Hill-Sachs is more of like a compression fracture, or to that humerus, and they'll have like a dent in it's on the posterior aspect, because when that humerus comes forward out of the socket, it hits that glenoid fossa. So the Bankart can be either from one or multiple anterior dislocations. And so that's like the anterior portion. Okay. And then the Hill-Sachs, like I said, you can see the little dent on the head of that humerus because of the sliding forward, causing that compression against the glenoid. And all of these, whenever you're evaluating, you're not going to know whether you have a Bankart lesion or a Hill-Sachs. This will be done like all through MRI. It's just the complications that come with it. Okay. And then there again, the labrum. Okay. Another one, you can get you have that periosteum that covers the bone, and that can peel off, and it's also a result from dislocation. That labrum will fall away, and then it's also known as ALPSA, which is anterior labral periosteal sleeve avulsion. So back to that other one. So you can see it. Right here. So there you can see the normal joint, and then with the lesion, see how that's pulling away. And you're getting all that return right there. Third base lesion, and this is very similar to the periosseal one, and this is just where it's more, this is where it's more with the scapula, right? Reed?
This, well, this is the same place as Benny
It's the same, okay.
And so it is, I mean, the injury's on the scapula, so that's your glenoid right there. So you get the
Yeah.
labrum that kind of sticks off the edge. But again, that labrum is, I mean, it's cartilage that's attached to the bone, so you're effectively tearing that chunk of cartilage and peeling it much like a banana off the bone for the most part.